All right, it looks like we've been able to get a lot of people in here now, so we're going to get going. If you haven't joined a webinar, you are on mute. If you haven't joined a webinar with Vitalware, I should say. Everybody is on mute to eliminate background noise, but we will be taking some live Q&A at the end. Should have some time for that. If you have questions, please do use the Q&A panel at the bottom of your Zoom interface there. That will keep us organized and make sure we can answer those as they come in. Other than that, there is no CEU for today's webinar, just FYI for everybody. And let's get right into it. Today's webinar is on the topic of price transparency. It's on everybody's mind nowadays. And it is presented by someone that has a very long history about creating solutions that help hospitals. He is Vitalware's co-founder, and he is Kerry Martin.
Thanks, Dusty. Everybody can hear me fine, Dusty?
Sound good to me.
Good, good. All right, good morning, good afternoon to those on the East Coast. Let's jump right into this. Our standard disclaimer, just letting you know, these are the opinions of mine, and we've come up with a lot of things that obviously need to be run by your chief compliance officer or chief legal officer. But we will give you a lot of information and recommendations around how to handle the price transparency regulations. So Vitalware is a mid-revenue cycle solution vendor, completely SaaS-based or software as a service. So we're in the cloud on any kind of hardware or browser. And we've been number one in class the last 2 years in a row. The reason why that's important is almost 1,000 hospitals are now using that platform, but that is also the platform that we're using to address the regulatory requirements of pricing transparency. I'm going to go through just a quick summary of where the lawsuit's at. There's been some added information and documentation on that. Go through the fact sheet that CMS produced. Level set on some definitions, and then really get into the strategy that Vitalware has come up with, which first and foremost is meet the mandate, meet the requirements. The second thing is we want, all hospitals have said this to us, they want to be transparent. They feel like this is the right thing for patients. But the data that CMS is asking hospitals to put onto the internet is pretty invasive. And so we're really trying to come up with strategies out of how we somewhat camouflage that data, and then also what data should we actually put up? I mean, is it everything that we've performed one of, or is there a threshold of volume that we should be looking at? So we have some thoughts and suggestions on that as well. Get into some of the product features, the data requirements, and then finally our recommendations. So when the lawsuit was originally filed, a lot of the authors of different articles thought that maybe the judge would rule in the short term for the hospitals and give them some more time. And as we know, on June 24th, the judge did rule, and unfortunately, he didn't rule in favor of the hospitals. And CMS basically said they have given the hospitals well over a year to accomplish this from when the proposed rule went into effect and then the actual executive order was signed. So there is a appeal that's been written. I read the response from CMS to the appeal, and they continue to lean on patients have a right to know this information. They've given hospitals plenty of time. And then they're also saying, well, the hospitals have already put the charge masters online 2 years ago. So there's just a lot of things that really make it pretty difficult to really have the judge do anything different than go forward with the regulations and the ruling. I think the one thing that may or could happen is maybe a relief on the actual allowed amounts down to the payer plan level. But at this point, it doesn't look like that appeal is going to actually be addressed and really an opinion given until after the first of the year. So it's really after the requirement goes into effect. When we talk to transparency committees and teams, we're talking about 3 different displays. So we've talked to hundreds of hospitals in the last couple months. And for some reason, everybody's stuck on the shoppable or on whether or not they should give an estimate. And so there is actually 3 different displays required. The display from 2 years ago is the chargemaster display, which was everything from the chargemaster. Now, what the government figured out from that exercise is the chargemaster is not very valuable to patients. Secondarily, all the OR codes, many of the things that are soft-coded by the HIM departments, are also not living in the chargemaster. So they covered that this time with the all services display. So there is an all services display that they talk about being machine readable. And then there's the shoppable services display, which is the 300 items. CMS has come up with 70, and the hospital is supposed to come up with the other 230. So those are the 3 different displays. We don't believe the all services and shoppable look that much different, but they want shoppable services to definitely be human friendly and for it to be searchable. The all services talks about more of a comprehensive view, and they don't mention the concepts of searchable. If you provide an estimate to your patients, or if you're standing up an estimating tool, then that takes away the shoppable services component. So it is all services, shoppable services. Shoppable services can be done away with if you provide an estimate. So that's kind of where the lines are with regards to the chargemaster versus the all services versus the shoppable services. Effectively, we're displaying a price list of payer allowed amounts. They do talk and want you to go down to the payer plan level. They actually use the words payer plans in a separate column or tab. However, we run into volume issues. And I'm going to talk quite a bit about volume, because volume to me is if you don't have enough of these, if you haven't done enough of them, then you can't feel good about it. We, a couple of weeks ago, ran into a $200,000 nosebleed. We don't know if it was a data entry error on the very expensive coagulation drug, but there was 10 units of that drug. It was very expensive. It ended up being a $200,000 nosebleed. Well, that is obviously going to inflate the prices of every other nosebleed that you've done in a year's worth of claims data. So we just feel strongly that deviations in volume need to be taken into consideration when you're looking at the all services display. Government payers, TRICARE, workman's comp off the table. They did clarify Medicare Advantage is on the table, and they put the requirement into the new IPPS ruling around filing a cost report that has your Medicare Advantage median payer negotiated prices. So the government has wasted no time taking the data from this exercise and now making it a part of the cost report. We believe the 835 is the most accurate and streamlined approach to displaying allowed amounts. That is our methodology. There is definitely the concept of trying to use a modeler tool and model things out. We do have a modeling partner for those hospitals that interpret the regulations as you should model out every potential service that you give. But we believe that the remittance data was mentioned in the final rule, and the 835, again, is the most accurate and streamlined approach. Long term, if patients become better shoppers, service package benchmarks is going to be critical for hospitals to understand where they sit in the competitive landscape. So we have added a component to our offering that is service package benchmarks. So you'll be able to see what's the hospital down the street charge for a total knee or a colonoscopy or a breast biopsy. And we've used the CMS data to build out service packages in the same way that we're building the service packages for hospitals. I remind everybody, machine readable file is not a downloadable file. We don't want to make this easy for the data miners. And if there's anything that we do that CMS doesn't like, we don't have to worry. We know CMS. They will continue to refine the requirements, add additional components. So most hospital CFOs have said to me, less is more. This is a homework assignment, and we want to get a passing grade, not necessarily an A+. All right, so let's go through the fact sheet. This is what CMS published as a final fact sheet after the final rule was put into the Federal Register. And I'm just going to go through some of the components. So the first component, it says, requirement for making public all standard charges for all items and services in a machine-readable format. They want gross charge, payer-specific negotiated charge, which is their term, and it's the same term they used in the final rule for IPPS, de-identified minimum and maximum negotiated charges, and a cash discounted price. At the bottom, CMS says they believe that this information and format is useful for employers, providers, and tool developers. Well, it's also valuable to the government. It's important for payer negotiations and your competitors. So we want to be thoughtful as to what do we put into this all services and how can we somewhat camouflage the data. In the middle of the screen, they talk very specifically about include a description for each item or service. And they talk about service packages, which is any code, for example, HCPCS, used by the hospital for purposes of accounting or billing. This is where they've incorporated all of the surgery codes. This is the language that says we want everything that's got a CPT or HCPCS on it. That's how you typically negotiate with your payers. And they definitely want the information that doesn't live in the charge master that's typically soft coded. So service packages, which is where we've spent a ton of time. Our compliance officer, Jennifer Bishop, has over 3,500 service packages built. It incorporates the drugs, supplies, anesthesia, etc. And I'll get into how we have formulated those service packages. Then we go into the shoppable services where CMS identifies the 70. Some of those are inpatient, some are outpatient. They want the hospital to come up with another 230. They want plain language descriptions. They want you to update this at least annually, although many hospitals have expressed some concerns that their major price increases go into effect July 1 or October 1. So there is the notion of maybe doing this a little more often than once a year. And this is where they incorporated into the final rule. You can see that very specific. They want the median payer-specific negotiated charge to be put onto the cost report, and it's for any and all of your Medicare Advantage organizations. So to level set on some definitions, what's gross charge mean? Well, for us, it means either the CDM price or the total claim charge. Payer-specific negotiated charges is really a CMS term. We know that as negotiated allowed amounts. Discounted cash price is a discount you give to a cash paying patient, not necessarily incorporating poverty levels or discounts that you give for different levels of poverty. That's more in the charity care policies that you have. This is just a pure, do you give a discount for a patient that's just going to write a check or give you a credit card? De-identified minimum and maximum across your payers and plans. And then I say service packages are single instance claims. So we're not talking about the fall off the ladder, bump the head, break the arm, twist the knee. There's too many things going on that claim for us to break out the supplies and the drugs, et cetera, accordingly. So we are really looking for kind of the plain vanilla cardiac cath or colonoscopy or total knee. We're not looking for the colonoscopy where the physician accidentally punctured the bladder or the colon and then rushed them off to emergency surgery, which inflated that whole event. So we're really looking for plain Jane procedures that are being performed in those ORs and procedure suites. Like I said, machine readable is not downloadable. I can't stress that enough. There's lots of different formats. Again, a developer is going to know what to do and be able to scrape the data, but there's no reason for us to just make it a click and download an Excel file or a CSV file. There is a penalty, as we all know. It's a pretty stiff penalty, but Medicare has actually followed up with some other documentation. They talked about they're going to give you a written warning. They're going to do a corrective action plan, which sounds like an integrity agreement to me. CMS is then potentially going to publicize hospitals that fail to comply with being transparent to patients. So the monetary penalty is one thing, but there's definitely some PR considerations for hospitals who are deciding or determining maybe they won't comply. So our hospital price index product, HPI 2.0, is the second version because we started doing this for hospitals with our ChargeMaster platform 2 years ago. So we were displaying the ChargeMaster. We were genericizing the descriptions. This time around, we're going to utilize claims data. We're going to take, and I'm just going to use the example of a total knee. We're going to take and look at all the plain Jane total knees. We're going to look at the highest claim, the lowest claim. We're actually going to publish those two numbers because we think that that's really good for patient education, that not all total knees are charged the same for a variety of reasons. The time in recovery, the time the physician takes, the implants that are used, etc. So we're looking for that total knee. We're looking for the lowest total knee claim, highest total knee claim, and then we're going to average, let's say a hospital did 100 total knees, we're going to average those 100 total knees, and that's what we're going to display for the gross charge for that total knee. We are going to use the CDM revenue and usage data to determine the individual items and services. We are going to assist hospitals if they aren't doing an estimating tool with the shoppable services listing. We're going to grab the de-identified minimum maximum when we get all of the 835 data collated. We're going to display the average allowed amounts for each of those contracted payers and plans if there's enough volume. And again, volume is a big consideration. Provide a back-end system. We have a complete ChargeMaster tool. It allows you to move columns around, to filter on different columns. You can have as many columns in our ChargeMaster tool as you need. So if it's 50 payer plans or 20 or 100, our ChargeMaster tool doesn't care. So that is why we're using the ChargeMaster as a backbone, because we really have a pretty unlimited data set. So for those hospitals that have 50 or 75 plans, no problem. We can handle that amount of data and put those into separate columns. And then, as I said, the benchmarking at the service package level, super important for the long play for hospitals and really determining where you sit as compared to your competitors. This is the inpatient list. CMS gave us the concept of 470. 470 is a joint replacement for lower extremity. So we know that patients aren't going to come to us and look for a lower extremity joint replacement. They're going to be looking for a total knee. They're going to be looking for a hip or an ankle. So we believe that CMS was not granular enough with this listing, and it's not very patient friendly to expect patients to type in a search lower extremity when that wouldn't be something that they would typically be typing. So we have a problem with vocabulary and patient searches, and we have a problem with the volume or the data that's associated with every joint replacement that takes place below the waist. So we've decided the best thing to do for patients is to break that out. Hips look quite a bit different from a gross charge perspective as compared to ankles and knees. So again, we believe breaking those out using the ICD-10 PCS codes is the most patient-friendly approach, and it also allows us to wrap some vocabulary around the concept of hips versus the concept of knees or ankles, rather than having a patient do a search for a lower extremity, display lower extremity, and then have all of that data sitting in one bucket. So that's how we're approaching inpatient. With outpatient, we kind of go the other direction. CMS, again, gave us some guidance on what they wanted us to put as a part of the shoppable list. Again, shoppable converts to all services. The two different displays, shoppable and all services, or the all services and an estimate, should not look that much different. And we actually bring up concerns to our hospitals as to how are you building out your estimates, and what's the philosophy when CMS says, well, we want this 43239 code, a biopsy of the stomach. Well, what about the other 10 codes that live in that same family? CMS gave us no guidance for that. So we've decided that we're going to take these families of codes, the biopsy of the esophagus, stomach, or small intestine, and we're going to bring those codes together. We're going to bring those claims together. we're going to bring those allowed amounts together. So this creates a certain amount of camouflage, but it also helps us with volume issues. Because if we looked at every one of those individual codes and then went to every individual payer that we have contracted with, we get to onesie twosies. And nobody can feel good about displaying the data if you've got 1 or 2 claims. The law of averages says we at least need 11. CMS themselves, in the CMS data use agreements, when we buy claims data from CMS, they require us to not display data if there's less than 11. So we're using the CMS data use agreement as a guiding light as to how much volume is necessary for us to feel good. So that's our kind of line in the sand. Some compliance officers said, nope, I'm going down to the onesies and the twosies, which is fine. Our system will accommodate that, no problem. But we believe bringing these families of codes together is patient-friendly. We believe it helps us with volume issues. We can then assess how those all services look and make sure that shoppable services lines that CMS has dictated to us look the same way, that it's all the same data, all collated in the same methodology. You will see sometimes we use ranges of codes. Again, creates a certain amount of camouflage. CMS constantly uses ranges of code. So it's this code, and this code through this code. Again, that helps us with searching. It helps us with volume issues, and it tends to camouflage the data to a certain degree from the data miners. We are creating patient education information. We feel strongly about hospitals publishing information or videos or something that helps the patients become better healthcare consumers. The primary information that we're trying to get patients to understand is not all hips are charged at the same exact amount for a lot of different reasons. Not all colonoscopies are the same for a lot of different reasons. These different CPT codes in these families, those are technical differences between those CPT codes that we don't expect the patients to understand, but we're trying to get all of that information published in a very user-friendly, readable way for patients to become smarter healthcare consumers. This is our 1.0 version. So this is the version we created 2 years ago where we showed the charge master. All that displayed was the hospital name, the charge master, the logo, and there was a searching component as required by the regulations. We did genericize the descriptions. The reason we genericized the descriptions is because trademark names and sizes of catheters and sizes of bone screws made it very Google friendly. So a patient could take your ChargeMaster description, go into Google, and a bunch of wholesale houses would show what hospitals were paying for that. So we had hospitals that had drugs out in their ChargeMaster. We'd go to drugstore.com and we'd see that, you know, there was 600, 700, 800% markups, and we just didn't feel that was good for the hospitals. So we genericized the descriptions. We said, this is anti-nausea medicine. We took away the route administration. We took away the actual dosage. We just let it live out there in the description, and we called it patient-friendly. And it definitely, like I said, took the Google friendliness out of the description. So that's what we did for our hospitals 2 years ago. Over 200 hospitals, this is how they display their ChargeMaster. It does meet the machine readable component. If somebody wants to paginate through all the lines in the ChargeMaster and copy and paste this into Excel, it pastes perfectly. So each of those columns would paste into separate columns, which actually is a test meeting the machine readable component. So that was version 1.0. Version 2.0, we make the patient pick the payer first and foremost, and we make the patient do a search. So before we display any of the data down below, they have to pick a payer. They have to search for something. Biopsy. They'll see all the biopsies. They pick biopsy of the bone. They'll see that line item. So we really size down the data we display. We don't display it in this long list anymore. We, on the Shoppable tab, we actually force the patients to do the search, pick from a list, and then only display that row of data. So again, it would be very hard for data miners in the Shoppable area to build a database with the way that we've designed the way the searching works. They can search for CPT codes unless it's in a range. So again, a data miner can't just put in any CPT code and get a line of data. It really is camouflaged with those ranges of codes. So if the code is published, then yes, they can search on it. If the code is in a range, then obviously they can't search on the ones that are within that range, which we again feel protects the hospital's data from data mining. When we go to the All Services tab, it looks very much the same way. However, some of our hospitals have actually asked us to truly put it into machine readable format, not human readable format. So we do have an option that is the very cryptic machine readable format. Again, any developer can look at this and know exactly what to do to parse the data out into a database. But this paginates at 25 lines per. It is very machine readable, so it meets that component. The display at the top says this is the All Services display. It is in machine readable format, and it's not intended for patient use. About 25% of our hospitals are choosing this method of display. We still make the patient or the person that's trying to get to this data pick a particular plan. But if the hospital says, nope, I don't like that machine readable display, then our display would look just like this. So really no difference, except for the All Services is not a searchable component. Our compliance officer really reads that the All Services should just display. And so we're going to, again, paginate at 25 lines per, but very much not searchable unless you want it to be. So every component, every feature that I've talked about is really an on or off feature that the hospital makes the final call, and decision is coming from the compliance officer or chief legal officer. So that's the two different displays for the version 2.0. And again, must pick payer. We only show one payer column at a time. All right, so service packages. I touched on this, but building a service package is really looking through all of this. And this is, again, a total knee example. I know some hospitals maybe on the phone don't do total knees, but the concept is the same. We're looking at all services that are typically done in the OR. We're typically looking at the drugs, the supplies, the recovery that is involved. In the case of this total knee, there's the joint device and bone screws. There's the knee x-ray. There's the blood draw and the CBC. There's the fentanyl that makes them go to sleep, and the actual joint procedure, the very bottom line. So that bottom line is what we're looking for, and we call that the parent code. We take and look for all parent codes in that family. Remember, there may be 2 or 3 variations of that CPT code for total knees, and we grab all the claims data. We bring that together. Then we go to the 835s to get the allowed amounts for these same claims. So if this $49,000 was the largest claim that had taken place of all my total knees, that would go in the high column. If the maybe $26,000 was my lowest, that would go in the low column, and maybe my average for my 100 is $32,000, which would go in that column. So I'm going to go back for a second. So you see the columns of data, the gross charge, that's the average gross charge, the low price, that's the lowest claim, the high price, the highest claim. So those first 3 columns are actually gross amounts, the low, the high, and the average. The next 3 columns are allowed amounts. So the Blue Cross allowed amount, even though it says a charge because we're using CMS vocabulary, the minimum charge and maximum charge are, again, the de-identified min and maxes, but they always talk as a charge. Those headers are, again, yours to decide. So if you want to call it allowed amounts, you can do that. If you want to call it negotiated amounts, you can do that. But those headers are really whatever descriptors you decide is most explanatory to the patients. So that's how we make or build those packages. And like I said, we've got 3,500 service packages built. Most hospitals typically on the all services display are around 2,000 to 2,500. And just in the service packages, we've got over 3,500 built. Then we load it all into our ChargeMaster tool. We see our publish buttons right at the top of the tool. You have complete control as to what you publish, when you publish. We do believe this is an iterative process. We don't believe that you're going to have a perfect data set on January 1. Great. change it some more, massage it some more. The ones and zeros in the middle of the screen tells our system what to publish. So if you change everything to zeros, you're going to publish nothing on day one. If you put out 100 ones for the packages that you feel really good about, great, publish that. The next day you feel good about another 50 or another 20, great, push the publish button. Every night our server is going to take whatever has been published and it's going to produce it out into your internet display. So there's a link on your site. It comes to the data displays that I've already showed you here. And that data is completely determined within the backend system where you can massage every field of data. You can determine what's published and not published. You have your average charge amount, your discounted cash price. You have your gross high, gross low. You have your Blue Cross, your de-identified, your Aetna, Cigna, and the columns just keep continuing off to the right. The professional charges are a requirement for employed physicians, and if it's being billed under the same tax ID number, most hospitals have said to us, that's a separate entity, it's a separate tax ID, they're not going to do it. So if you have employed physicians or providers being billed on the same tax ID, there is a requirement to publish the professional component. We are displaying that professional component separately because some hospitals have employed physicians, some do not, and we don't want this to be an apples to oranges comparison. You don't want your patients seeing yours are bundled in and they don't understand that. And the hospital down the street doesn't have employed physicians, and so their prices look significantly less. Well, it's because of that professional component. So we're displaying it, but we're displaying it as a separate line. And again, your chief legal officer, compliance officer needs to make the call as to, with your employed physicians, if they're being billed on the same tax ID, then it is a requirement according to the regulation. All right, so now we need to do some litmus tests. We've got all this data in here and we need to start massaging. Now, it's about a 60-day implementation process to go back and forth and look at this data. There may be some things during the spin up of the data that are just not quite right or don't look right, and we need to really start looking at that. So we've lined up our prices from our charge master with our prices from our claims for what we consider the individual items or services. So you can see in the service single or package, if it says single, it's coming directly from the charge master, but we want to see what that looks like when it goes out on claims. Because maybe the charge master is not the guiding light. Maybe the claims data is actually better data. And I'll get into that in just a few minutes. So that's the first litmus test, is just lining up the individual items from the charge master with how those things look when they go out on claims. Then we look at the service packages. Now, we've built the service packages. We've bundled in the drugs, the supplies. In that very first item, you can see it's a drainage of a breast cyst. We've included the ultrasound guidance as a part of that package, but $19,000 is our procedure, and it's a package, and you can see the very first thing it says is all services. It's got a 1. So we're going to publish that one line item. Underneath it, all the packaged items are there. You can see the roll up of the average gross charges over in the 6th or 7th column that roll up to that $2,900 number, but we're not publishing the components of the package. So again, very easy for you to manipulate the data, to see how we've formulated the data, to see the allowed amounts in those different columns. So all of that information is there on display. Anything is editable. You can change all the ones, like I said, to zeros, and you would publish absolutely nothing. If we don't have data or don't have enough data in a particular allowed amount column, then we just show blanks. So you can see there are several instances where we don't have enough data for Aetna or Alliant, and we just blank those columns out. We can't display data if we don't have it or we don't have enough of it. So our approach, again, is at least 11 claims. Some hospitals are saying, well, yes, but in a year's worth of data, I would think that maybe 20 is the right threshold or maybe 40 is the right threshold. Again, CMS says if you purchase data from us and there's less than 11, don't display it. We purchase that data quarterly, So we're bound by 11 per quarter. So that's why some hospitals are choosing 40 on an annual basis, referring back to the CMS data use agreement. So again, really nice litmus test, good to see all the data in a display, and can scroll off to the right to see all of my payer columns. If I want to pull some payer columns off to the left, I can drag and drop them. I can create views and filters on the left-hand side. I can save those views. So I really can create a bunch of different views to help me manage this data and make sure that it's right before we actually publish it out to the internet. So service package benchmarks, I've mentioned this a couple times. I think this is, again, the long play. This is real data. This is our hospital that was really helping us develop this back in June and July. This is their colonoscopy data. It's $9,312.85. Their neighboring hospital right down the street, $7,554. And their hospital about 25 miles away, $6,577. So this actually, was the most important thing to them, is how do they sit with these service packages as compared to their neighbors. And so they're now doing an assessment of what they need to do. As everybody has said, a lot of times gross charges don't matter anymore, but it really matters when patients start looking at the data. And to be able to drive 30 minutes and save $2,800 is something that most patients would probably do. So again, patients are not the smartest healthcare consumer at this point. They're going to be looking at those things. And so we've decided that service package benchmarks is something we're just including as a part of this product. Some hospitals came to me and said, well, Kerry, but we get paid on fee schedule for a lot of our lab codes, and I would just rather display the lab fee schedule that they've given us. And I said, perfect, no problem. Our tool has always been able to import data, import fee schedules. We've always in our ChargeMaster tool been able to run lesser of reports. So if you do have fee schedule data for some ranges of your procedure codes, we can load that in. We do it with the CPT or HCPCS that's associated with that. We can do some of the packaged or lab panels that we can bring in as well if they've outlined that in those fee schedules. But we can totally mix and match the data coming from the ChargeMaster, coming from fee schedules, coming from claims, and coming from your 835 remittance files. So this is a combination of bringing 4 different data sets together. Click on any line item, you can edit it. Off on the right-hand side, you just tab through the fields. Again, you can edit anything. There is an ability to do a multi-edit. There's an ability to edit it in Excel and import it in. And there is an ability to use our workflow tool if you want your department directors to be spot checking some of their service packages, then we can definitely implore the workflow tool to be able to do that. As far as data requirements, 1 year's worth of claims data, 837s, 1 year's worth of remittance data, 835s. Like I said, we built the service packages from CMS data, but we will use your claims data when we validate those service packages. Things like C-sections, labor and delivery, we don't have a lot of data, obviously, in the Medicare data set for those, so there's a lot of PED procedures and OB procedures that we really need your data for. But all the ones where we do have the packages already built, it's a validation process with your claims data. We do need payer fee schedules if you feel strongly about displaying that. We need the, if you have contract modeling data, then we can use that. If you feel strongly about modeling data for some of your payers because you've just renegotiated contracts, then we can use modeling data instead of 835 historic data. Need the ChargeMaster and fee schedule, and they need the revenue and usage for the ChargeMaster as well. The physician ChargeMaster, as I mentioned, the professional charges are required for employed physicians if you're billing under the same tax ID. Okay, so one more exercise. A lot of hospitals came to us and said, well, what's this look like? I mean, when you're deciding what to display, so this is the all services selection process. So it's a two-step process because we have to do it with claims data and we have to do it with the CDM. So I'm going to go through the CDM and we can see that we have 7,800 line items in our CDM. We see our charge code, our UB. Some of our line items have HCPCS, some do not. We see our CDM price and we see our outpatient usage. So we see we have some volume issues. Again, our recommendation is at least 11 services. Some hospitals are saying, yeah, but I think 40 services over the course of a year would be the right number. It's, you know, again, are we getting a passing grade or an A+ on this assignment? Once we filter by volume, we have a list of 4,390 in our charge master. We already have our charge master online. There's no reason to display all the 272s and 250s again. So we're going to filter that out. We don't contract with payers based on HCPCS codes. So again, our thought process is this is all about allowed amounts, and the allowed amounts are not negotiated. We don't negotiate needles and suture kits and sterile trays with payers. So we're going to remove all the 272s, 250s, and anything that doesn't have a HCPCS line item, and we're down to 2575. So now we need to say, is there duplication in my charge master? Do I have 100 C code 1713s, which would just be confusing to the patients? So again, we think that this has got to be patient friendly, and all these orthopedic screws and pins and rods all over the charge master is confusing. So we believe there should be one line item for each HCPCS code, and we shouldn't have multiple line items because it's got different prices. So when we do the pivot on that, on the left-hand side, for whatever reason, this hospital's got 3 different 10060 incision and drainage codes, 3 different prices. We believe that should display as one price. So we've decided, okay, over on the right-hand side, you can see 10060, about the 5th one down, is $378. But now we need to lay that down next to our claims data, because as I said, maybe the claim is a better number than what's in the charge master. And that seems sort of counterintuitive, but when we lay it down next to the claim file, we can see the second line item. There's that incision and drainage code of an abscess. 360 is the revenue code. 10060 is the CPT. In my charge master, I have the $420 price displayed. In my revenue and usage, I have 25 of them. And on my claims data file for that particular code, I am constantly sending to Medicare $557 as my total claim charge. Well, it makes perfect sense. There's a sterile tray, there's a suture kit, there's a scalpel involved in that incision and drainage. There's some numbing medicine. So this is the granularity that you have to start thinking about is, am I just going to display charge master prices, which is not what I send to payers. It's not what payers pay on. So in this instance, rather than doing 10060 as a code from the charge master, we decided to make that a small service package. And we're going to push out the claim charge and show the claim as the average charge, because that's what patients ultimately see. That's what payers see. That's what payers pay on as far as allowed amounts. And that our 420 price is really not the guiding light, but the claims is. So these are the things that we've thought through and done a lot of data exercises with our clients to try and make sure we know what is the information that we want in the service packages versus what is the information that's going to display as an individual item, probably coming from the charge master. So hopefully all of you have formed pricing transparency committees. You've got the chief legal officer and compliance officer reading through the regulations and trying to interpret all the things that they didn't say with regards to the regulation, which is what we've been trying to do, is what do we do in this instance or this instance or this instance when there is really no guidance. So that's the biggest thing. The second part is benchmarking. Benchmarking 2-view chest x-rays, MRIs of the head, CTs of the head with or without dye. All of that benchmarking exercise probably needs to take place because eventually you're going to be compared to hospitals down the street or in the next town. And so doing some one-offs, benchmarking exercises with your ChargeMaster data is a pretty easy exercise. Picking out the 230 shoppables, there has definitely been some relief and some data published around, critical access hospitals that don't even do 230 services. So it really comes down to, and CMS themselves used utilization about 30 times in the document as they were discussing the shoppable services. So there's no doubt that utilization has to be a component in picking these 230 that are outside what CMS defined for us. But remember, CMS also said if you don't do one of these 70, you have to identify that you don't do it. You can't just not display it. It has to be identified. And our tool does that as well, it identifies those ones that maybe you don't provide services for. Policies and processes, scripts are an important, what happens when a patient brings in a screenshot of this data and the data is showing compared to their bill significantly different. The patient's in charge a lot more than what's on the website. Making sure policies and processes are in place. We've talked to a lot of hospitals that have been doing estimates for quite a while and crossed a lot of those bridges and have those scripts in place, but it's definitely something that you need to have a discussion about. Recently, some of our hospitals have brought up, the concept of enlightening the board. So your board of trustees or the governing body needs to be in the know, because once this goes public, they may get some phone calls and not even know that this is going on. So definitely making sure that not just the executive team has a plan, but that those board members are informed as well is something we've heard even recently. And Dusty, with that, there may be some questions.
Yeah, perfect. Just a couple questions here. We'll get right into it. Again, if you do have a question, please use the Q&A panel and we'll have a go at it. First question, what is the source for your service package benchmarks and how frequently is it updated? Are the package prices proprietary and based only on bundling you have done for other hospitals, or is a public data point available for a wider set of competitors? A lot there.
Yeah, so we're using the CMS data set to create the packages. So the pricing that we're building is public, and that's why we're able to display that. We're going to display 2 competitors for each hospital, but it is public data. We built the service packages ourselves. We really tried to use the claims data to begin with, but then we did a lot of carve-outs where we associated chemo drugs with chemo administration and stuff. So there was a lot of associations that we did in these service packages that are somewhat proprietary, but yeah, all the pricing data and anything that is that wider data set for comparative purposes, for the most part, it's coming from the CMS data set. Now, we run your data set with our service packages, and so when we get done running against your actual claims data, then it kind of really becomes your service packages because your data is going to be better than just your data that you've sent to just Medicare. So it is a little bit of a combination. We get claims data every quarter, so we always have run claims data. So our thought process is that we'll run the data at least a couple times a year to freshen it up. So that's kind of the thought process at this point. Some of our hospitals have said, because of our year end, we want you to run the data twice. We include 2 complete data munges in a 12-month period just because you may have some significant changes in payer negotiations, price changes or whatever. So we've already committed to all of our clients that we're going to spend the data, redo the service packages at least twice a year. So I think I hit all the components of that question, Dusty.
Yeah, I think so. Nice work. So one more question here. If our payer surgery rates are loaded but require a Rev 360 or 361 to pay the rate, and we bill with a non-surgery rate like Rev 761 or 940, that will pay a different rate. Will this be able to display the correct rates per the Rev codes that we actually bill?
Well, I've never gotten that question before. And I'm thinking through whether or not that data is coming through. Because we're using 835 historic data and we're connecting it to the claim, then I would think that we're going to see the 360 and see the amount you've charged for the gross charges component, and then we're going to see what the payer paid based on that claims data. So I think we're covering that, but definitely send an email to us, or we can take this offline and have a discussion that gets into the granularity that you're discussing. But I think we do it because we use your claims data. We see the rev codes. We know your gross charges. We see the 360s. We know your gross charges. And we know the allowed amounts that the payers are giving for any given claim. So if it didn't answer, definitely get a hold of us and we can take it offline.
Yep, perfect. That is the last question. We did go a little long anyway, so we are about out of time. Again, if you do have questions or you want to follow up, especially that person answered that question, the easiest way to do that, just go to our website, vitalware.com. We have live chat on there, or you can submit a contact us form and we will make sure to follow up with the right person. Otherwise, we appreciate you joining us today, and we'll talk to you soon, I'm sure, in a future webinar. Thanks, everybody.
Thanks.